Professor von Cutsem, thank you very much again coming to talk on eCancer television. I really appreciate that very much indeed.
Pleasure for me.
We have a really interesting meeting here in Nice. The program is a good mix. It's a lot of translational stuff. Ongoing clinical trials are being sort of highlighted. You're presenting several things. What about the clinical trial front? What's the most exciting thing that's happening?
I think that you see that in different meetings, translation research is so important because we really have to go towards individualisation and personalisation of cancer treatment. And also this meeting is on colon cancer only, but if you look in different cancer areas, and in my area, colorectal and gastric cancer, for instance, there are two nice examples there that the molecular markers are really going into clinical practice also. In the adjuvant treatment, we can discuss about microsatellite instability, that in stage 2 colon cancer, for instance, patients with a microsatellite unstable tumor, they probably do not have any benefit from 5FU-based treatment. So in stage 2 colon cancer, we always discuss should we treat a patient with an adjuvant treatment for 6 months, yes or no? We know that in some patients there is a benefit. We know that in other patients, in a lot of patients, there is no benefit. We usually base our decision on clinical and pathologic factors.
This kind of stuff.
Yes, not
quite.
Not really the wet finger, but more on clinical and pathologic information, such as is there vascular invasion, is there perineural invasion, how many lymph nodes have been...
Classic TNM stuff.
Correct. And now we see that the data on microsatellite instability are being validated more and more. So in that sense, that patients with an MSI, with a microsatellite unstable tumor, stage 2, that it's unlikely that they do have any benefit
from any fluoropyrimidine.
From a fluoropyrimidine, yes.
Why? Or why not?
We do not understand completely, but the different smaller studies have indicated that, and there was a meta-analysis also indicating that we don't understand biochemically why this is, but it's a fact, and the data are consistent. What is clear also is that it's not the only factor. For instance, a question that I was asked recently at another meeting when I presented some data is, what do you do then in a 35-year-old patient with a T4N0 tumor, so a stage 2 tumor with vascular and perineural invasion and poorly differentiated tumor who is microsatellite unstable? And I said, MSI is one of the factors. We don't throw away our microscope. The microscope is still very important, but it adds on in the decision taking. So that's one aspect. And then another aspect is, of course, in the selection of patients treated with biologicals. We know that they are not cheap. We know that some patients clearly do benefit in metastatic colorectal cancer from biologicals, but the challenge is to select patients who do benefit and who do not benefit. For bevacizumab, the angiogenesis inhibitors, we do not have markers, although there are some early data from retrospective small studies. They have to be validated and they are not yet ready for clinical use. That the SNPs, the single nucleotide polymorphisms, may help us in the future to select which patients do benefit more or less. And then for the
this is an angiogenesis. So
bevacizumab is an angiogenesis inhibitor.
What kind of SNP are you talking about then?
We are
predict for angiogenesis inhibition?
Looking and talking about SNPs in the VGF, the vascular endothelial growth factor receptor. Again, it's not validated. It has to be validated, but there are already...
But it sounds logical.
There are two examples already that's of clinical data. That's one in breast cancer, one in pancreatic cancer. And again, it's more retrospective studies, but I'm just telling that because it can give us some, let's say, some hope for the future that we can also select our patients. And then there is a whole story that was developed over the last 2 to 3 years on the anti-EGFR, anti-epidermal growth factor receptor antibodies, cetuximab, panitumumab, where the KRAS story has been validated, where we know that patients with a KRAS mutant tumor, they will have no benefit from cetuximab or panitumumab. That does not mean that all patients with a KRAS wild-type tumor, that they will benefit. There we have to look further. There are some of the interesting data on BRAF, on the ligands, amphiregulin, epiregulin. So they're coming through. We need further validation. But if you see the speed on the validation of the KRAS. That was done in 2 to 3 years, so I'm sure that in the next couple of years we will see more data on this.
And the story of not all wild-type RAS patients will respond to the appropriate targeted therapy is just the same as trastuzumab and HER2/neu in gastric, or tamoxifen, or any of the estrogen drugs in estrogen receptor-positive breast cancer.
Correct, it has some similarities. Yeah. And the other example that I gave in the beginning was in gastric cancer, where we have seen now for the first time that a biological can have some benefit and can have a clinically meaningful benefit in patients with a HER2 positive gastric cancer. And this was recently also approved by EMEA. Especially if you then look in the subgroup of patients that with a strong expression of HER2, and we defined that as immunohistochemistry 3+ or immunohistochemistry 2+ for HER2, followed by a positive FISH test. Yeah. And that's around, according to the experience in the TOGA trial, that was 16% of the patients. That's not a large number of patients, but remember in breast cancer also, the trastuzumab is benefiting only the HER2 positive patients, and that's 20 to 25% of the patients. So it's meaningful, and it's important that we can go into this individualization of treatment. And that's, I wouldn't say what's all about, but that's important if we want to make really important steps forward.
It's definitely where it's going. So there are two options. One is what are the other pathways, the BRAFs and so on, which are some explanation for the failure to get a target hitting a receptor and something happening. The other issue, of course, is where you have got it right, believing the receptor assay. Mm-hmm. And eCancer TV has got a wonderful teaching module at the moment from Beppe Viali, who's the reference lab for all the breast cancer HER2/neu assays. And he's been showing some alarming data of labs getting the HER2/neu assays seriously wrong. Yeah, and the grading. I mean, you were stressing 3+ immunohistochemistry or 2+ plus FISH positive. That's fine in your excellent lab in Belgium and my excellent lab in Milan, but can everybody do that?
Yeah, you're pointing out to a very important aspect, and for that, if we go further into the HER2 testing in gastric cancer, we have learned in the meantime that HER2 is very heterogeneous in gastric cancer, much more heterogeneous than it is in breast cancer, where it's a bit more homogeneous. Having said that, it means that there are even more challenges that we have to take into account. So there will be for sure a learning curve in this. And for instance, this week we have in Belgium a consensus meeting between clinicians and pathologists to try to come up with a consensus to try to upgrade and to make the learning curve for the labs as short as possible, because that's as well as an important part of the whole setting. And if we do select the patients in the wrong way, then we will not have the benefit that was shown in the clinical trials, where all the biopsies were examined in a central lab. So that's very important.
Now, you have another hat. You have many other hats. But one of them is that you're the medical director of Europacolon. Mm-hmm. And I was speaking to Yola Gore-Booth 2 minutes ago, and she was telling me about this exciting patients meeting, colorectal cancer patients meeting in Lisbon. Is this really the first time that people have got together, your bowel cancer patients in Lisbon from all over Europe? Sounds very exciting.
Bowel cancer patients are starting to organize themselves thanks to Europacolon on different countries. What happens and what happened already is that in some countries there were some different initiatives. Bowel cancer patients are not yet so well organized than, for instance, breast cancer patients or prostate cancer patients. For different reasons. You see that as well in Europe as you see that in the US. Breast cancer patient advocacy patients are better organized and stronger.
Very eloquent, highly intelligent, middle-class women.
There are different reasons. I can't judge the different reasons, but there are different reasons for that. And it's a reality that this is an important aspect, focusing on different parts. And one of the important aspects is awareness of patients, of symptoms.
This meeting in Lisbon is a first for cancer patients from Europe who've got colorectal cancer, and it really seems exciting.
I think it's important because patients are looking for information everywhere, and colon cancer patients are now being organized through Europacolon in different countries, and a forum is really needed for this patient advocacy groups, and Europacolon does a bit more. Jola explained to you that for sure in detail, but the screening aspects, the awareness, the access to optimal care, quality control of care, that's all important, and that's going to be some of the topics that will be discussed. And personally, I gave my support to Europacolon because I do think that it's very important to give with a scientific look and as accurate information on non-healthcare professionals, and therefore I completely endorse this initiative.